Good evening and welcome to Macular Disease Foundation's first webinar of the year, focusing on the impacts of dementia and macular disease on people living with both conditions. So my name's Vicky Heaton and I work for the Macular Disease Foundation as the Healthcare Relations Manager, and I'm also a practicing optometrist in DY New South Wales. Before we begin, in the spirit of reconciliation, on behalf of MDFA, I would like to take a moment to acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea, and community. We pay our respects to elders, past and present, and we extend that respect to all Aboriginal and Torres Strait Islander peoples today. Firstly, some housekeeping. So all attendee cameras and microphones have been turned off. If you do have any questions, then please enter them via the Q&A icon, which you can see at the bottom of your screen. Your questions will be answered at the end of the presentations, but please feel free to type them out at any time. The webinar has been accredited by Optometry Australia for 1 clinical CPD hour, and the learning objectives are up on the screen now. So before I introduce our speakers, I'd like to take a moment to share some information on how we at the Foundation are working to support health professionals like yourself in the important work that you do. We have created a one-stop shop for everything macular disease related. The QR code there on screen will take you directly to MDFA's health professional webpage, where you can easily order patient resources. We have a free e-newsletter for health professionals called Mac Matters. It comes out quarterly and it provides updates on our services, on research, and lots of other useful information. And we've also got a range of CPD options for lots of different health professions. You can access relevant accredited courses and recordings of our past webinars. So I encourage you to jump on the website and have a look around. So without further ado, I would like to introduce our first presenter, who is Evelyn Doak. Evelyn is a dedicated professional with an extensive career in TAFE education, specialising in business studies, information technology, and workplace health and safety. Her expertise extends to the community sector as a Dementia Australia advocate, where she has contributed significantly to raising awareness and supporting those impacted by dementia. Evelyn is a passionate advocate for quality nursing home care and is a strong believer in person-centred care. She will not accept situations where people with dementia are left without stimulation, activity, and connection with other people. Evelyn's career exemplifies a strong commitment to education, advocacy, and community engagement, underpinned by her dedication to making a positive impact in every sphere of her work. This evening, Evelyn will generously talk about her own experiences as a carer for her beautiful mother, Frances, navigating macular disease, dementia, and the aged care system. Welcome, Evelyn. I'll hand over to you now.
Thank you, Vicky. Thank you for the opportunity to be part of this presentation today and to share my mother's story. My mother, Frances. My mother, Frances' history regarding her eyes was that she was diagnosed with dry macular in 2011. She started eye injections in 2011 at Sydney Retina Clinic. They continued for 10 years with intervals between 8 and 12 weeks. Previously, she had reoccurrences when she was extended past the 12 weeks. And then her dementia was diagnosed in September 2016. Mum then had both cataracts removed. My father then passed away in February 21, and my mother moved to Port Macquarie to live with me. However, due to her challenging behaviours after living with me for some time, my mother was later moved into the aged care unit, into the dementia ward. At a local residential care. I then continued on with the Port Macquarie eye specialist. The Sydney Retina Clinic sent a referral to the Port Macquarie eye specialist, and we continued on with the eye injections from April 21 to December 21. As you know, dementia impacts cognition. So by December 2021, all contact with an eye specialist was discontinued due to the confusion and the stress that it was causing mum with the eye injections. My mother passed away 3 years afterwards. Mum's daily medications for eyes and checks. She was very adamant about her Macutech tablets and her fish oil capsules. In addition, there was a little chart on the fridge that she said was a very important chart and that she had to check her sight with it. I later found out it was the Amsler grid. However, in the last 12 months of her life, swallowing became increasingly difficult, leading to frequent choking episodes, even on the pureed foods, and therefore we had to stop her tablets, her capsules and her tablets. And then mum actually had aspiration pneumonia and passed away in November last year. The issues with the eye injections, mum had a struggle with hearing loss, and being in the dementia ward, she had misplaced both her original and her replacement hearing aids. Unfortunately, other dementia patients were taking things out of her room, which is a common thing in a dementia ward. And as her advanced dementia made a hearing test impossible, communication became increasingly difficult, particularly as she was having the eye injections. So we purchased an audio amplifier, and a tile tracker was placed on the amplifier. And this way I could track, if ever they said they'd lost it, I would come in and track the amplifier down. However, on the first event of an eye injection in Port Macquarie, I fear that the specialist's office had very little dementia training. When we arrived, they insisted that I not be with my mother and that I be away from where she was, and they placed her on the operating table. Obviously, with her hearing, she didn't hear what they were saying and didn't understand what they were saying. And I was placed so that I could still have line of sight. I made sure of that. And she tried to get off the table. And luckily, I made it to prevent her fall, which would have been terrible. Strategies to assist mum with her vision loss. Mum always loved to read, gradually lost interest in reading. So to help with that communication as her needs changed throughout the day, I purchased a magic whiteboard, and this simple tool made it easier to keep her informed and reassured. I would print such messages as the lunch menu, fish and chips today, mum, or gentle warnings like it's almost shower time, or the carer's name that came in. I could easily rub it out and put it on the next one quickly. So I was constantly able to talk. And she loved to read that. She could read that when it was large print and black, and I held it very close to her eyes. And of course, we reminded her we loved her. Issues in the dementia ward were, as I said, frequently other residents were wearing her prescription glasses. And when I've raised that on arriving, they'd say we can't take them off that patient, that resident, because that resident becomes upset. So therefore, my mother sat without her glasses because of not wanting to upset the other resident wearing the glasses. So because we kept missing the glasses and the sunglasses, we decided that we would lock them away. And we went up 3 to 4 times per week for about 3 to 4 hours per time. So we gave mum the glasses then, and she was able to read in her earlier and mid dementia. The issues again in the dementia ward, there was no eye examination. So once we stopped with the eye specialist in December 2021, we had over 3 years of no knowledge as to how her eyes were going. She experienced recurring eye infections while in the care. We repeatedly asked the GP, could we have some antibiotics or something for the eye infections, but we were usually only given sustained eye drops and often a wet hot washer for her eyes. The photos you see here are not photos I've taken, otherwise I would have had her hat and sunglasses on. These are photos that were sent by the aged care facility to show me that mum's having a lovely time out in the parks, etc. So they often lacked proper eye protection during our outdoor activities, and many did not have access to any sunglasses, leading to discomfort and the potential eye strain, as you can see with mum trying to look without glasses or a hat. Recommendations I'd love to see is that we ensure residents receive regular eye checkups with a specialist that could come into the dementia ward to maintain optimal eye health, and then implement a secure centralised system for storing and labelling the glasses, making them easily accessible for the outdoor trips where they could just go to a locked cupboard and get the sunglasses, pop them on, each person with their name on them, and they hop on the bus or wherever they're going. And train the staff in the importance of eye care for dementia patients, in particular those with macular degenerations, ensuring sunglasses are provided when they're needed. Again, thank you very much for allowing me to share Mum's story today. Thank you for the opportunity.
Thank you, Evelyn. Thanks so much for sharing those experiences of managing dementia and macular disease. I think your insights have really struck a chord here tonight on the significant gaps in the system and just the real importance of the carer. Your story actually really resonates with me, as I know you know, I worked as an optometrist in the aged care sector for many years, and I've witnessed many of the things that you described, and I really can't imagine what it's like going through with a loved one. So thank you so much for being here tonight to share such a personal story. So I'd like to introduce our next presenter, Dr. Marianne Coleman. Marianne is an early career researcher and orthoptist. She's worked in the UK National Health Service and later trained in clinical research. Marianne moved to the University of Melbourne in 2020 to work as a clinical vision research fellow between the Department of Optometry and Vision Sciences and the Australian College of Optometry's National Vision Research Institute. Marianne now works at the National Centre for Healthy Ageing, a collaboration between Monash University and Peninsula Health. Marianne's pioneering dementia research has been funded by the UK Royal Society of Medicine, Fight for Sight, the UK's leading sight loss research charity, and the Dementia Australia Research Foundation. Her research has been guided at each stage by people living with dementia and carers. Welcome, Marianne.
Thank you very much, Vicky, and thank you to the Macular Disease Foundation for inviting me to speak alongside Evelyn about this really important topic. So I will just share my slides just now. Hopefully everyone can see that okay. So I will be revisiting Evelyn's experiences with her mum, Frances, throughout the rest of this session. So thank you very much to Evelyn for sharing your story and your mum's story as well. So just to recap on the learning objectives, we're going to do a whistle-stop tour of what dementia is and what it isn't, and the types of dementia that you might encounter in your practice. Evelyn has already given you a sense of some of the ways that dementia can impact upon macular disease care, and I'm just going to add a little bit to that. We'll go through why it's so important for all of us as eye care professionals to do everything we can to support people with macular disease and dementia to keep engaging with treatment for as long as possible, just as Evelyn has with Frances. And lastly, I'll share some strategies that might be helpful for providing that support to people living with dementia and their families as well. So, what is dementia and what is it not? Dementia is the most common neurodegenerative condition. There are over 400,000 people living with dementia in Australia, and that's just people with a diagnosis. It's actually more common a condition than this due to the time it can take to navigate the memory clinic system in order to obtain a diagnosis of dementia. So this is 8.4% of Australians aged 65 and above who are affected. And given that optometrists are supposed to be seeing people annually when over the age of 65, the chances are quite high that you will be encountering this group in your day-to-day practice, with or without a diagnosis. So dementia prevalence increases with age. It's 8.4% of Australians 65 and over, but it's more like 1.5% for the general population. However, despite this, dementia is not part of natural aging. as dementia can happen to people under the age of 65 and even children. So, dementia is a disease process. The Australian Institute of Health and Welfare have pinned dementia as the leading cause of disease burden in people over the age of 65. And we refer to it as a disease because research has shown that just like macular disease, dementia can in some instances be prevented or delayed in onset through medications and engaging in risk reduction activities to address modifiable risk factors related to lifestyle and health. So, 2/3 of people living with dementia are actually living in the community and therefore will benefit from support and access to community eye care, whether it be from optometry, dispensing opticians, orthoptists, or ophthalmologists. It's also really important to remember that people just like Evelyn are out there and may be your clients as well. For every person living with dementia, there are many people that are providing support: family, friends, and neighbours. Evelyn cared for Frances as long as she could, and aged care is often the place of last resort. So, the key message to take away from this is that dementia is out there in your community, and therefore, as a clinical practitioner or somebody who is supporting eye care in optometry practice, you will see people who have it or people who are carers for someone who has it. So, dementia is the most common neurodegenerative condition. It's not part of natural aging, and dementia is an umbrella term. There are over 100 types of dementia. So, let's go through some of the ones that you're more likely to encounter. I'll say right at the beginning that what I'm going to go through here are the differences between dementia types in the early to middle stages. The late stages of dementia can become more similar between types, with difficulties with swallowing, like Evelyn mentioned, loss of continence, and so on. So let's talk about dementia types. Firstly, there's Alzheimer's disease, which is the most common type of dementia. So maybe one that everyone is already familiar with. Now, this is what everyone thinks of when you think of the word dementia. You have dementia, you must have memory problems. And in Alzheimer's disease, yes, that is a key early feature of it. But with Alzheimer's disease, you can also have problems with your spatial vision too. This type of dementia can affect the parietal lobe, which is a big player in depth perception, so our stereopsis, and spatial navigation as well. Let's move on to vascular dementia next. This is the type of dementia that can happen after a stroke or repeated transient ischemic attacks. Pretty much any kind of visual difficulty you'd expect after a stroke can happen in this kind of dementia. It's a bit similar to Alzheimer's disease in terms of what it affects, and there are sometimes people who have mixed dementia, which refers to somebody who has both Alzheimer's disease and vascular dementia. There are some other types of dementia that can overlap as well. So, for example, you might have a patient of yours that comes to see you and says, I have Alzheimer's disease. But later on, they might then say to you, oh, I've been told that I had a brain scan and I've got Lewy bodies as well. So let's move on to younger onset dementia, of which Lewy body disease is one type. So dementia is not just a condition that affects older people. There are some people that are diagnosed before the age of 65, and this is referred to as younger onset dementia. And not all types of dementia start as problems with cognition. Dementia is not just a condition that affects memory, it can affect many other aspects of our brain function as well. So let's talk about some of the types of younger onset dementia. Lewy body disease is definitely one to know about, as this can be associated with visual hallucinations. So Parkinson's disease is actually a type of Lewy body disease. And again, we see quite a few people with Parkinson's disease in our day-to-day practice because they often have problems with binocular vision and also dry eye due to reduced blink rate. So you can divide the different Lewy body diseases into what comes first, the movement difficulties or the cognitive impairment. So in Parkinson's disease dementia, the movement difficulties come before the cognitive impairment. Whereas for dementia with Lewy bodies, it's the other way round. But as mentioned, you can get visual hallucinations in both of these types of dementia, as well as Alzheimer's disease as well. Next, I wanted to talk about frontotemporal dementia. This is another type of younger onset dementia. And the important thing to remember about this type is that the memory difficulties come much later on. So if you go to somebody and they tell you that they have frontotemporal dementia, it is not appropriate to treat them as if they have a memory difficulty unless they are much more progressed in the disease journey. So there's one type of variant of frontotemporal dementia that is mainly characterized by behavior changes. So this is called behavioral variant frontotemporal dementia, and this can be associated with things like loss of inhibition, changes in mood, and so on. Alongside this, there's also a language variant of frontotemporal dementia, which is sometimes referred to as being primary progressive aphasia. So for this type of frontotemporal dementia, communication difficulties occur fairly early on in the course of the disease. And this can affect all types of communication, which is really relevant to all of us as clinicians. So that's an example of some of these different types of younger onset dementia. The final type I wanted to talk about is posterior cortical atrophy. I don't know if we have any Terry Pratchett fans on the call, but this is the type of dementia that Terry Pratchett experienced. This is actually a subtype of Alzheimer's disease, but the deterioration and the buildup of proteins starts in the occipital cortex. So people with this type of dementia can experience really profound visual processing difficulties. So these are some examples of the different aspects of visual processing that can be affected by posterior cortical atrophy. Now, I had the partner of somebody living with posterior cortical atrophy contact me literally last week saying, "Hello, I'm not sure if my wife's glasses are doing anything for her anymore. Can you tell me where I should take her to get an eye test?" So this type of dementia is quite rare. It affects only about 5% of all people living with dementia. But again, these people are out there and really benefit from having that access to eye care delivered by people who know about dementia. So it's worth telling you about this type, mainly because of these kinds of visual difficulties. So that's a really whistle-stop primer on different types of dementia. So to sum up this section as a whole, dementia is common, and there's many people living with different types of dementia in the community who need your help. So what's all of this got to do with macular disease? So I mentioned that the prevalence of dementia increases with age, and it's the same for macular disease as well. So what kind of overlap are we looking at here? There's 1.9 million people living with macular disease. There's 400 and something thousand people living with dementia in Australia. So we actually have very limited information about the actual extent of overlap between these two conditions here in Australia. These numbers that I'm giving you here are based on a UK study finding about 18% of people living with dementia also had some level of macular degeneration, even if it's early stage. And this number could go up to 80,000 plus if we're also considering people with diabetic retinopathy who may have some level of macular edema. So what does this overlap actually mean? Does having macular disease increase your risk of developing dementia or vice versa? I just saw that somebody's already posted a question in the chat asking about whether treatment for macular degeneration could increase your risk of developing dementia. So macular disease and dementia are both degenerative diseases. So is there a relationship? Does having macular disease increase your risk of developing dementia? The current research seems to indicate that no. As far as we know, there isn't a link in that way. But if you have macular disease and dementia, you are more likely to experience vision impairment than somebody who doesn't have dementia. So that's the really key thing. So let's talk a little bit more about that. Up to 1 in 3 people living with dementia may experience some level of sight loss. Again, this is a UK study. We actually have very little in the way of proper prevalence data for that here in Australia. And this UK study found that just simply by living in residential aged care, your risk of experiencing sight loss is doubled. Okay, so why are people living with dementia more likely to experience vision impairment? Why does this happen? It's because people living with dementia experience barriers to accessing eye care. And as Evelyn has said to you, people in aged care, just like Frances, are even more likely to miss out. People living with dementia are less likely to have regular eye tests, and that's whether they live in the community or aged care. They're less likely to receive anti-VEGF injections, especially on an ongoing basis. As Evelyn has shared with you, injections may not always be able to be continued forever. But in some cases, if people develop macular disease after developing dementia, they may not be able to access this care at all. And the same is for cataract surgery, receiving ocular lubricants and other types of topical medications like glaucoma drops, all that kind of stuff. So here is a really sad graph to share with you. This is a study that was done in Scandinavia, and it is showing a really sharp drop off in the rate of cataract surgery for people living with dementia in the time period immediately after a dementia diagnosis. So it's just a fundamental fact that people living with dementia are less likely to receive these eye care services, especially if they develop eye problems after dementia. So what else does the topic of dementia have to do with macular disease? Let's talk about risk factors. What I'm showing you here now is the updated graphic of what we call modifiable risk factors for dementia. These are all factors that can increase your risk of developing dementia if present. And you'll see that vision loss is the most recent one to be added, specifically late life vision loss, just like the kind of vision loss that you can get if you have age-related macular degeneration and other types of macular disease like diabetic macular edema. So, what does this have to do with macular disease? These risk factors for dementia are applicable to people who haven't developed dementia, but it's reasonable to assume that these risk factors for cognitive decline don't just magically go away after you've got a dementia diagnosis. Now, you might have already spotted the link between these two topics while I've been going on. So some of these risk factors for dementia are also the same things that can increase your risk of developing macular disease or so AMD or diabetic eye disease. So alongside this, some of the knock-on effects of living with vision loss are more dementia risk factors. So if you can't see well, you feel less confident going outside, you stay home more. If you struggle with conversations or taking part in activities because of your central vision loss, you do fewer social activities or see people less. Poor vision and balance can increase your risk of falls. And if you feel socially isolated or lonely, you're more likely to have mental health difficulties such as depression and anxiety. It's no wonder that researchers have noticed that vision problems are prevalent in people who go on to develop dementia later on. It's quite tricky to untangle all these risk factors when there's relationships like these going on. But ultimately, what I'm trying to say is that if you encourage your patients, especially those with early stage macular changes, to make lifestyle and diet changes to reduce their risk of further progression or developing it in the first place if they got a positive family history, you're actually helping them to look after their brain as well. So addressing these risk factors also has a knock-on effect on brain health as well, and vice versa. So for this reason, the prevention strategies are really important for people living with dementia and early stage macular changes. So the final thing I wanted to touch on for this section was the impact of central vision loss specifically for people living with dementia. Any form of visual impairment is not great for this group of people. Distortions or scotomas associated with macular disease. So again, talking about the Amsler chart and the importance of using that to detect these things. All of these things can have a significant impact on people living with dementia. Features of faces, use of visual aids like clocks, calendars, smartphones, photos. There are some great activity programs out there to support people living with dementia as well, but these are rarely adapted to accommodate sight loss. You may have supported many people with macular disease who have just stopped going out. And this is really detrimental for people living with dementia as well. And the other thing as well is that this affects falls risk. And falls are really bad for people living with dementia. We want to do everything we can to prevent falls for this group. Because if people living with dementia have a fall and it's an injurious fall and they end up hospitalized afterwards, then people living with dementia are at such a greater risk of developing delirium if they go into hospital compared to people without dementia. And sight loss is another risk factor for delirium as well. And if people living with dementia develop delirium, if they have a delirium episode, this can increase their risk of further cognitive decline. And you know, some of these folks, they have a fall at home and they never go home again. And that's just sad. And there's so much that we can do to help people to try and prevent this. So the other thing as well that I wanted to emphasize is that vision impairment also affects family carers as well. So there is research to show that for carers of people living with dementia, they spend more time on care tasks for that person if that person also has vision impairment compared to people who have dementia but don't have vision impairment. So it affects everyone. It compounds the issues of living with dementia. It makes living with dementia harder, living well with dementia harder, and it affects families as well. So we want to do everything we can as clinical professionals to prevent or delay sight loss for people living with dementia because it just makes everything so much harder, accelerates their loss of independence and transition into residential aged care, which you know everyone wants to grow old at home. It's only natural, and you know we all have a really big part to play in that. So what can we do to help people living with dementia and macular disease? That's the kind of $1 million question, really. So I'm going to break this next section down into key parts of the eye examination and how you can obtain the info you need to develop a suitable management plan with the right support. And this is focused on dementia specifically rather than general macular disease care principles and strategies. You know, there's like 300 odd people on this webinar. I'm preaching to the choir here on this. So the best I can do is to give you the tips more specifically focused on dementia and dementia-friendly eye care. So number one thing, you may not know that your patient has dementia before you start the consultation. We did research, we interviewed optometrists. We know that a lot of the time you don't know, you haven't been told, and you are figuring it out as you go. People living with dementia may not disclose their diagnosis for a variety of reasons. They might maybe have a sunflower lanyard or something like that. This is becoming more popular. In Australia, the use of a sunflower lanyard to indicate hidden disability, but a lot of the time you may not know. There's a lot of reasons why people living with dementia may not disclose that diagnosis to you. They may not see the point in telling you if they do not see how it would change things for them. They might not necessarily have insight into their condition, or they might come alone without a carer or any other support for their eye test. And they may just simply assume that you already know. And these are all quotes from people living with dementia who we spoke to and asked, would you tell the optometrist that you had dementia? And for a lot of them, as far as they're concerned, the eyes and the brain are completely separate, and therefore they would not tell you, because why is it relevant? So that's just a bit of a starting point for this. So all of my tips are based on you somehow magically knowing that the person has dementia. There's a few clues that can help if somebody else has made the appointment for them, for example, then that can sometimes be a little bit of a hint. But if nothing else, assume nothing before you start. So don't make assumptions about people living with dementia. If you take nothing else away from this webinar, remember that once you've met one person with dementia, you've met one person who has dementia. Everyone's individual presentations of dementia and their associated difficulties and symptoms may vary hugely from one person to the next, even if they have the same type of dementia. And you are much better off assuming nothing. People living with dementia can sometimes really rise to the occasion of a medical appointment and be able to really kind of impressively navigate the initial parts of the consultation, like exchanging greetings. Even when they have communication difficulties, they can sometimes still come out with familiar phrases. And so cognitive impairment or communication difficulties may only become apparent as you go on. So assume nothing from that initial meeting. If the person's come along with someone, you can ask if they would like to be present during the appointment. People living with dementia in the community may go for their examination alone, to the hospital or so on. But having a carer present is usually a help rather than a hindrance. So if you've got space in your testing room to accommodate somebody else to be there, it's well worth inviting them in if they've come together. So in terms of the case history, it's important to ask about whether anyone has power of attorney for healthcare decisions, because you might need to involve them in decisions around treatment, such as referral to the eye hospital, for example, if the person with dementia prefers supported decision making. And the new Aged Care Act that is coming in has much more of an emphasis on the importance of in trying as much as possible to support people living with dementia to make their own decisions about their care. So it's useful to know who else has power of attorney in that arrangement. If the carer is present, you can do a collaborative case history and you can identify things like risk factors for progression and so on. People with communication difficulties or changed behaviors may not necessarily answer your questions as you might expect. So, for example, if anxious about the appointment, somebody living with dementia might be quite keen to please and to give you the answers that you're looking for. This is known as a fawn response. So they might tell you what they think you wish to hear rather than what's actually going on. And so having a carer or somebody else present to scaffold that case history can be quite helpful. But living in care arrangements are really helpful to ask about. Driving status. Don't assume that just because they got dementia, they've stopped driving. There's a lot of people, especially with early, younger onset dementia, who are still living in the community and still driving. So be mindful of that. Ask them about how they got to the appointment. This is relevant later on. I'll talk more about that later. Sometimes people living with dementia can start to have difficulties with managing their other comorbidities. So, for example, if they have diabetes, sometimes people experience other sensory changes. So they might have change in their taste and what foods they enjoy, and that might also have a knock-on effect on their diabetes self-management. So just be mindful of stuff like that. And asking about supplements, as Evelyn said, Frances is very good at taking her supplements. So, don't just assume that all of these kind of routines have fallen by the wayside. So those are all important things to think about. So, adapting testing. Now, when we interviewed people living with dementia and carers about their experiences of having an eye assessment done, cognitive fatigue was the number one thing that they really, really struggled with. Doing an eye exam is exhausting. All of these subjective questions about people's vision is really, really tiring. So be mindful of that and think about what are the really key tests that you want to do. What are your objectives for this visit? Demonstrations can really help with understanding. So pointing at the ear that you want somebody to look at on the slit lamp rather than letting them figure out for themselves what ear is left and which ear is right. So demonstrations can help with understanding. And remember that dementia is a disability. So focus on what people are able to do rather than what they can't do. If you try something and it doesn't work, move on, basically. So this table on the right hand side here is from this UK study that I keep going on about. You can see that there's quite a lot of components of the eye examination that even people with more advanced dementia can still take part in. So 88% of people living with dementia, and this is a big sample of people, this is like 700 people living at home or in aged care, who were still able to do an objective refraction. And even some of them were, the majority were still able to do a subjective as well. So it's only things like visual fields, which can, the cognitive impairment, the cognitive fatigue really kind of kicks in on the visual field test. I mean, it's tiring for everybody, right? But it's especially tiring for people living with dementia. So that's just an example of the fact that people living with dementia can still take part in many parts of your testing with the right kind of support. So recognize when enough is enough. A longer appointment can often be quite helpful with that. And the reason for that as well is because adaptations to testing and communication can take time. But it's important to do these adaptations because they help the person living with dementia to feel able to take part in the testing. And that will increase the chances that you'll be able to get reliable results to inform your clinical decision making. I also just wanted to emphasize as well that it's important to assess contrast sensitivity. I don't have a lot of time in this webinar to really go over the nitty-gritty of adapting the different eye examination components. So if you really want an in-depth deep dive on that, then do our training course, which I'll talk about at the end. But for contrast sensitivity, I just wanted to highlight this because for macular disease in particular, we all know it's important to assess this, but it's even more important for people living with dementia because many types of dementia are also associated with reduced contrast sensitivity. So this is a really important thing to know about when tailoring your management plan and thinking about making recommendations like lighting. So I've got a little bit of time left. These are the things that I wanted to recommend in terms of management. Okay, so these are things that can be done anytime and you don't need to wait for any visual impairment come in. So number one is referring to MDFA's iConnect service. So that early engagement with MDFA and their patient support services is really, really helpful. And you don't need to wait. As soon as they have a diagnosis, you can start engaging in things like risk reduction strategies straight away, which is the next thing that I wanted to talk about. So getting started with things like diet changes, increasing physical activity, supplements, sun protection, as Evelyn has said. This is a seniors exercise park that's right here in Melbourne, where I'm broadcasting to you from. These are high contrast. This one is pink, but there's yellow ones as well. And know about dementia activity programs and seniors exercise parks in your area because these have been designed to be helpful for people that want to increase their physical activity levels. And there's walking groups and cafes for social activities, all sorts. So it's good to know about what's in your area. Evelyn has talked about glasses. It's a huge problem, especially in residential aged care. So a lot of residential aged care optometry services offer things like engraving. So it's well worth knowing about whether these services are options within your own place of care and what other strategies are available from a dispensing perspective to help reduce loss and breakage of glasses. So things like spring hinges, durable frames that are, a bit easier to repair. These are all things that you can kind of think about. And lighting. I cannot emphasize this enough. Falls prevention is everyone's responsibility. We all have a role in this. I've done home visits for people living with dementia, and the level of lighting in some people's rooms can be absolutely diabolical. And with both dementia and macular disease contributing to depressed contrast sensitivity function, it can really make a noticeable difference to navigating the home safely and keeping people reading for that little bit longer as well. As Evelyn mentioned, Frances really loved reading, and it's always a shame for carers to see the person that they love no longer being able to engage with and enjoy activities that they once used to. So anything that we can do to help with that kind of thing can be really, really helpful. So addressing cataracts promptly is also really key. We're trying to boost contrast and maximize vision. If you're seeing cataract and it's of a sufficient grade for extraction, there's no need to hold off on a referral if the family are happy to go private. So just bear that in mind. I know the public health system is in a bit of a state and the cataract waiting lists are not great, but the earlier you can get that referral in, the better, effectively. So it's worth talking about that with your clients, simply because as dementia progresses, it can increase the likelihood of the person needing to have that cataract surgery done under general anesthetic rather than local. And if they have it done under a general, it increases their risk of developing delirium. So, you know, you've really got a huge way up. It's a massive decision-making process for carers about whether to go ahead with cataract surgery at that stage. So really, the earlier, if you're able to do it, I know the system is not great in terms of setup for support for this, and it's something that we are hoping to work on in research in the future, but do what you can, basically. And lastly, you can also support the care of other ocular comorbidities. So managing everything everywhere all at once alongside dementia can be a lot for the person with dementia and for carers as well. And so just like MDFA, these other eye disease organizations are offering support programs that might be helpful. So again, it's good to know about these programs and what's out there. And for management, I also wanted to talk briefly about communication. So offer to see for them to see you again if possible, because the continuity of care is really, really helpful. It builds up a rapport and trust. Trust is so important, so important. And a sense of someone, if somebody's not having a good day, you know, people have good and bad days for their dementia, just like we have good and bad days for lots of things. And so sometimes if you know what they were like on a previous appointment, you can sort of see them again and be like, you're not having a good day today. Maybe we might just do a couple of tests and see you again some other time. So that's something to kind of think about as well. And also noting it, you know, what vision tests people engage well with. All of this kind of stuff can be really useful. If you don't have that opportunity for them to keep seeing the same practitioner each time they come and see you, then you can at least make those notes for the next person to help them out. And establishing communication preferences is really important. Some people living with dementia can have really quite complex care arrangements. So, you know, their main person who supports them might be interstate and visits, you know, once every month or two. Or they might have somebody that lives several hours drive away if they're somewhere regional or rural, for example. And so asking about preferences for who needs to know about appointments and sending reminders for follow-up. Would they prefer a phone call rather than a letter? And things like that is quite important to establish. And Evelyn spoke about the Amsler grid on the fridge. Everyone has a chart on the fridge, right? And not everyone is as good as Frances at remembering what the point of the chart was. I mean, this quote here from our research is actually from a carer who wasn't sure what the chart was for. And so, yeah, not everyone is suitable for Amsler monitoring. So if you are a bit concerned about that, then it might be worth scheduling a bit more closer follow-up if that's feasible for you to do. But the really important thing is to demonstrate what the Amsler grid is actually for. You know, help again, I mentioned about demonstrating what to look for is helpful. This is the kind of things that might look like, this is what to watch out for if you have a problem that needs urgent help. So having some kind of a comparison can be really helpful. And you can even attach this to the Amsler to actually connect the two things together, so it's really clear what the point of it is. And also agreeing an emergency action plan for sudden vision changes alongside that as well. So if you do have this, what are you supposed to do? Again, if you're able to write this down, if that's their preference, then you can do that as well. So that's the communication side of things, just a few brief tips on that. For intravitreal injections, this is where asking about things like transport arrangements and so on is really helpful. You're asking for a hospital trip every few months and support with any aftercare, and this might require a lot more organising if people do have these complex care arrangements. Evelyn was driving up and down the motorway to go and see her mum and dad in the early stages before Evelyn moved her mum down to be with her. So, you know, there's quite a lot of people that are caring from afar. And be mindful of what Evelyn said, that dementia training is not routine for eye clinic staff. You have no control over that person's experience at the eye clinic. There's currently no way to identify a dementia-friendly ophthalmology practice right now. And unlike the UK, there's no recommended processes for ophthalmology appointments for people living with dementia. So people are having to take their chances and hope it works out for the best. It's really important to check in during review appointments for this reason. So injections do not necessarily last forever. And so checking in for changes in circumstances or care arrangements or discontinuation of treatment. Ophthalmology does not go into residential aged care. If you've moved into aged care, the only way to access injections is to leave the care home, as was the case for Frances. So it's important to be realistic with families about intravitreal injections. Don't wait for something to go wrong. If a person's struggling to follow your instructions when you're doing your assessment or displays changed behaviors during that, like anxiety or agitation, Evelyn mentioned about Frances trying to get up off the table because she wanted to see Evelyn. This has ramifications for your ophthalmology appointments as well. So it's really important to have that communication with the clinic. If you suspect that there's something that might affect that person's ability to continue their injections, then you can share that. And so for that reason, it's important to have a plan set up in advance with everyone about what happens next. How are you going to monitor vision to avoid a situation like Evelyn's, where she was not sure how well Frances could see? What are you going to do about low vision aids? And so have a clear plan for that transition to low vision care. Guide dogs have just launched Seaware. I don't know if people have already been to some of the webinar content by guide dogs on this topic. This is for people with early to mid-stage vision loss. So as soon as people start to have changes in their vision, you can refer them to this service. People living with dementia and carers can have a real hard time of navigating the healthcare and aged care systems as it is. So don't make this just another thing that they have to get to grips with. You can use all of your knowledge and skills and these great information sources to help them know exactly what to do and when. Try and introduce those low vision aids as early as you can. Frances was good with her supplements because they were part of her routine. So if you're able to establish a routine with low vision aids, it might mean that they're more likely to be used later on. Involving people who are providing support can also help with establishing that routine, and so that everyone knows which low vision aid is needed for which activity. Again, you might like to write this down because there's a lot of different people that are involved in care and support. On the bright side, there's a lot of crossover between low vision aids and dementia friendly design. So this lamp that I've shown you here, this is a daylight lamp. It's got this nice big red on button. It's quite straightforward to operate. It's also worth checking in what people are already using, things like speaking clocks. There's quite a lot of people that have become quite proficient iPad and smartphone users who are living with dementia as a result of COVID. So it's always worth doing a tour of the accessibility features on mobile devices as well. And as Evelyn said, sometimes just keeping it simple with things like a whiteboard and a big black marker can just do the job. So you sometimes have to be a little bit creative, but we're all, any low vision practitioner is good at the creativity side of things and thinking outside the box a little bit. So I don't need to tell you that. And the last thing I wanted to touch on for this was just making everyone aware of Charles Bonnet syndrome. Charles Bonnet? Anyway, where there's a scotoma, it's important to make people aware of this because some types of dementia, like Lewy body and Alzheimer's disease, as I mentioned, can be associated with hallucinations. The hallucinations that people experience are really similar to those that happen in Charles Bonnet syndrome. So insects, animals, all of that kind of stuff. The management of the hallucinations is also quite similar. So it can be quite reassuring for both people living with dementia and carers to hear that if they have vision loss, that hallucinations are not completely unexpected and they might not necessarily be related to the dementia. So that about wraps it up for top tips. I'm happy to take questions at the end if we have time. And I just wanted to finish off by talking about interprofessional communication and some resources that we've got. So who needs to know about vision problems and their impact? The answer is everyone. There's a lot of different people involved in dementia care. Not all of them are proficient at translating optometry reports. I spoke to a geriatrician who said they just about figured out OS, OD, and OU. So try and write a letter in plain language detailing the issues and always involve the GP because they can cascade if needed. So be very clear about what is to happen at home when you're writing to these other professionals because they can also ask about it in their appointments as well. So about our resources, we've created information about dementia and eye health for people living with dementia and carers, ways to declare a dementia diagnosis to the optometrist and eye test support needs. you can update your Optometry Australia member profile if you are an Optometry Australia member. There's now a new dementia-friendly option there, so you can tick that box if you feel comfortable assessing this group. This is our training course. It's just recently been re-accredited by Optometry Australia. It's worth 6 CPD points. Even if you're not a member, you can still do the course. It's available at this link here and it'll be sent out afterwards. And we've also got a tip sheet for eye care professionals. This is free. It's on the Global Dementia website. You can search that. And if you're an optometrist, you can also check out our more detailed chairside reference in Optometry Connection. And if you want a real deep dive on dementia-friendly eye care, then do the training course. Pure and simple. All right, that's me. I'm going to hand over to Evelyn again.
Oh, it's actually over to Vicky. Thank you, Marianne. Thank you. What amazing presentation.
Oh, yes.
You've given us a lot to think about, a lot to digest, and so many ways that we can improve our practice. So I know I'm going to take a lot of takeaways from you. So thank you very much once again. Just a reminder for everyone to pop your Q&As if you've got any. There's already quite a few in there for Marianne and for Evelyn, and it's just at the bottom of the screen. So just while we while they have a look at the questions, I'm just going to give you a little bit of a quick update on our services. So basically, hopefully most of you will have heard of iConnect by now. We've been talking about it for a little while. It's been around for a year, well, almost a year. And it supports your patients basically in 3 different ways. So we have health literacy. We provide lots of information about disease status. We provide practical advice on living with macular disease. And also, most importantly, it's emotional support. And we've got a great team on the health line who call our iConnect users regularly. They've all got either an orthoptics background or an optometry background. They've been trained to address the worries and the concerns that people may have about living with macular disease. And at this point, I also wanted to mention that we can, and we do at the moment, offer this support to carers as well. They can also join iConnect. As you've heard from Evelyn this evening, carers, well, and Marianne, carers are really an integral part of macular disease management. And so it's just really important for our carers to know that they've got somewhere to turn to and support to access as well. So I've just got a slide up on how to refer. It's really quite straightforward. If you've got Oculo in your practice, you can use that, or we've got a website e-referral form or a good old-fashioned referral pad. And we've also got sample packs, which provide a snapshot of what a patient will receive over a 12-month period. So you can just scan the QR code there and follow the prompts on screen. And lastly, yeah, we're basically supporting around 500 people, currently just with age-related macular degeneration, but I'm excited to announce that we are kicking off diabetic eye disease in 2025. Our service is getting really great feedback from our users. There's 98% satisfaction rating, saying that they'd recommend iConnect to their family and friends. And I've just got on screen some snapshot of what our regular referrers are saying about the benefits of collaborating with MDFA for their practice and also for their patients. So we're going to be looking into the longer term impacts of iConnect on people with macular disease, and in particular adherence to treatments, and also the hopefully positive effects on patient well-being. So I'm now going to invite Marianne and Evelyn back on screen. So I shall stop sharing. And we shall have a look at the questions. So Marianne, I think you were happy to have a squiz in and have a look at the questions, because I know there's a few for both of you up there. Are you happy to kick off, Marianne?
Yeah, absolutely. I can knock a couple of these through. So Winston, can long-term anti-VEGF injections cause dementia? There is no research to indicate such a link at this time. If anything, people living with dementia are less likely to receive ongoing anti-VEGF injections compared to people without dementia. The current research showing the relationship between late life vision loss and risk of developing dementia, it's primarily focused on people who have not yet developed dementia, and we don't know as much about what happens to people's access to eye care after they develop dementia. As I mentioned, a lot of the studies that we've done are in the UK, and there's not as much going on in Australia. So the current epidemiological studies do not seem to suggest a link between receiving anti-VEGF injections and dementia. And an anonymous attendee, oh, actually, I think I've got these in the chat as well. Yes, Jenny. Jenny says that in a dementia ward, they should do lid hygiene and ocular lubricant for everyone to decrease the chances of eye infections. 100% agree. I have just received funding from Dementia Australia Research Foundation to design a dementia eye care pathway in residential aged care, and that is definitely going to be a feature. I was literally just talking to an optometrist today who described the delightful cheese texture of doing an assessment for people living with dementia in residential aged care who have not been receiving these lid hygiene support as part of their care. So it can be a really unpleasant and uncomfortable experience for them. And so, yeah, I 100% agree that it's really important.
We've got a question for Evelyn. How did you find the strategies such as the whiteboard for your mum in the aged care facility? Did you just figure them out yourself?
I did, yes. You're really on your own, I'm sorry to say. No one helps regarding eyesight. When I mentioned about trying to get even a doctor into the aged care, they said, no, you have to have the doctor that's here. There's lots of blocks, no matter what you try. I tried to get a physiotherapist in, and they said it'd have to be approved by management. I couldn't just get a professional accredited local physiotherapist in. I mentioned about eye. Was there someone that came in to do the eye checks? And they said, no, there was nobody. It was a block, just walls, constant walls. So you really were on your own, and you had to come up with your own strategies. And that's why I was working full time, but went straight down to part time because I needed to help my mother. I was her voice, and I took it seriously and kept trying to come up with the ideas.
And there's a
they
lot of
worked.
carers in Evelyn's position, yeah, having to advocate.
Absolutely.
Which actually,
Always.
it leads on to the next question quite nicely. Is there any support available for carers of those with dementia?
Dementia Australia is where I turned to try and find some information, and I was unaware of them because this was all thrown at me. Mum never told us she had dementia. We had to pick that up ourselves as we were living away from her, and it was only because she kept ringing us that we started to get an idea that she's got something wrong. So we were thrown right into it to try and learn very quickly about how to help. And then when my father died, it was even more so. It was drive to Sydney overnight to be with mum and take mum and pack her up to get back to Port Macquarie. So you're really thrown in the deep end. You are trying to swim on your own. And Dementia Australia did help us by me attending, becoming an advocate, and trying to learn as much as I could, and doing a MOOC training. Tasmania University had some MOOC training, and I took myself to that online and learnt what I could. And then I was fairly strong, opinionated, so to speak, about what I wanted for my mother. And I stood my ground, and I introduced things that weren't happening. Yeah, but it helped mum very much. And the smile was worth $1 million. That when she could read that whiteboard, she'd turn her head and she'd read it and she'd smile. And we were still I was holding on to her. That's all I wanted to do, was hold on to her as long as I could. And it really helped. Those strategies helped. Thank you.
Thank you for sharing them, Evelyn. I mean, this is all about eye care, but I think we'll all, remember this for any personal times as well in the future. So thank you. Marianne, were there any others? There's a few more coming through.
Yeah, I'm trying to type answers. Is there a place for PHNs to help optometry care in aged care? Should this be part of accreditation for care homes? Currently, it is not mandatory for aged care facilities to provide a visiting optometry service. And it is also not mandatory to report how many people were assessed when an optometrist does come to visit. And as a result, we have pretty much zero data about what the service gaps are. We do know that the number of Medicare claims for domiciliary optometry are much lower than they should be. So that's just a fact. But at this present moment in time, there is not a mandated position on provision of optometry care in aged care. So unfortunately, I cannot answer that question. On the similar topic, there was somebody who asked about remuneration for the extra time that these consults take. The Medicare flag fall for domiciliary optometry has recently been increased, but it's still not enough. It still does not recognize the fact that it does take more time. The government needs to recognise that people living with dementia have a right to access care from skilled practitioners with appropriate dementia training. And the National Dementia Action Plan, which was released by the Australian government not that long ago, does talk about the need for training, but there is no appropriate level of remuneration to recognise that level of practice. So watch this space, maybe it'll change in the future.
Okay, and there's just a question whether, just really simple strategies like having a cord on the glasses might be something that can be helpful in a setting. No.
No, because of other residents grabbing them and choking. So you couldn't wear any necklaces, nothing like that into the ward.
Yeah.
And that's why I was trying to go for the cabinet with the sunglasses in there at least. But yeah, it's all about behaviours.
Yeah, and there are other difficulties. If you use a sticky label on the glasses, then some people living with dementia will pick it off because they like to fidget. So there can be difficulties with that. Engraving is usually a big help in that regard, but yeah, there's not a lot of easy solutions for glasses, as Evelyn said. The recommendation about chains is mainly for people living with dementia in the community. That would be my recommendation for there. You can also buy these tiny little tracker things that go on the glasses. But again, if it's something that can be fidgeted with, then it will possibly get removed. Not everyone will do that, but some people will. So for people living with dementia, you have to have a very kind of holistic and person-centered approach. What works for one person may not necessarily work for the next person. Does the literature show if maximizing visual acuity through spectacles, etc., reduce how quickly dementia progresses? We do not have that data. Sorry, Nikita. There is very little research about what happens if you give people living with dementia the eye care that they need. It's an area for more research, pure and simple.
Okay. I don't know if we might have time for one last one. Marianne, I'm not sure if there's any more in there. Otherwise, it is.
Some people have asked about, Sean is talking about dementia doulas. They are a type of care navigator who can support you if you are living with dementia, and they're there for families too. So that's good to know about. That's kind of an emerging service here in Australia. There's also carers support networks. So I've worked with Carers Australia for some of my previous research. People have asked about smart boards. Again, there's some of the stuff that I've talked about with regards to accessibility features on smartphones and tablets and all the rest of it. There's a lot of care homes that actually have tablets, and they bring them out and use them for various things. So again, it's just worth knowing that that's an available option. If they can't get MacuTech with Blackmore MacuVision Extra Strength, be okay to recommend? I am not able to answer that question. I'm terribly sorry. I don't know if maybe anybody else on the webinar might be able to give you some advice about alternative supplements to MacuTech.
Oh, I think that's one that we'll probably leave for that's probably a whole nother webinar in itself.
There we go. Oh, there we go. MDFA have already answered this. Thank you very much. There we go. I don't need to say a word. You guys are already on it.
Thank you, Delaney, in the background helping out there. Excellent. All right. Well, I might say a huge thank you once again to you, Evelyn, and to Marianne for your time and your expertise and such a really wonderful webinar this evening. We really, really appreciate you being here today. Thank you to everyone who attended and for your support. And our next webinar will be in May, which is Macular Month. So we look forward to celebrating that with you all and seeing everyone then, hopefully. We'll say a good night.
Thank you. Thank you, Vicky, very much.
Yeah, thank you. And good night to everyone, all of our amazing attendees. Thank you for coming.
Thank you.